This conference will
This
now be
conference
recorded.
will now be recorded.
Okay, so we'll be
Okay,
talking
so
about the
we'll
last
be
part of
talking about the
this
last part of
bladder,
this bladder,
and that is cancer of the
and
gallbladder.
that is cancer of the gallbladder.
Initial disclosures and
Initial
acknowledgements.
disclosures and acknowledgements.
So we have these
We have these
the part that's taken up from the
part
internet
that's taken
and
up from the internet and
Love and Daily and
Love and
SCNA.
Daily and SCNA.
So India has a high
So
incidence rate
India
in
has a
gallbladder.
high incidence rate in gallbladder.
Accounts for 10% of the
Accounts
global
for
burden,
10% of the global burden,
and one of the three
and
leading
one of the three leading
causes of death.
causes of
Hello,
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 hello.
hello,
Hello,
hello.
Yeah.
hello.
Uh,
Yeah.
can you hear me?
Sir, some echo is there. Your
Can
sound
you
is
hear me?
coming
Sir, some
twice.
echo is there. Your sound coming twice.
There's echo now.
There's echo
Yes, sir.
now.
Yes,
Yes,
sir.
sir.
Yes, sir.
Yes, sir.
Okay,
Yes, sir.
I'll join again. Just a minute.
I'll join again. Just a minute.
Don't go away. Huh? Hello, hello.
Hello.
Now can you hear me?
Yes, sir. Now clear. It's clear, sir.
Okay, okay. So we just go back again.
This conference will now be recorded.
So we are starting with this last part of gallbladder, and that's the cancer of the gallbladder, a very important disease as far as this part of the country is concerned. Even otherwise, we as Indians are highly susceptible to this malignancy. First, the disclosure and acknowledgements that are routine, picked up from a number of internet sources, books, and journals. So the first, the epidemiology of gallbladder cancer is a high incidence and accounts for 10% of the global burden of gallbladder of the malignancies. And India has got 10% of the global burden of gallbladder cancer. See, we have got 10% of patients of the whole world. And the three leading cancers among women in the north and northeast India. So it's more common in the females as compared to the males. And the incidence is steadily rising in India, both in the females and the male population. And the most common age group is 41 to 60 years. And the average age adjusted rate among women has increased from 6.2 per lakh population to 10.4 per lakh population. So that shows you the steadily rising rate in India. Similar high incidence is seen in other geographical areas. Like for example, Bolivia has got 14 per lakh. Chile has got 9.3, Thailand 7.4, and so on and so forth. The USA has documented only 2 per lakh, but Native Americans in Mexico they show about 14.5. So this is just epidemiological comparison that we could just draw. Now, as far as the incidence is concerned, if you look at the incidence, we can relate it to a number of variables. The first one is stone-related figure. So we got 70 to 90% of carcinoma gallbladder would have associated stones, especially of the cholesterol type. So more often than not, when you end up with the carcinoma of the gallbladder, you'll find that stones are associated, and that association would be in more than 70 to 90% of cases. On the other hand, if you look at it in the reverse side, only 5 to 6% of symptomatic stones would turn out to have carcinoma gallbladder in the long run. Less than 1%, about 0.4 to 0.6% patients with asymptomatic stones have carcinoma gallbladder. Now, these are pretty important figures for the simple reason that they give you an idea about the therapeutics, they give you an idea about the prognostication, they give you an idea of to advise the patient. Now, you immediately say a patient, look, you've got gallbladder stones and you have a chance of having malignancy. Now, he would ask you, what are the chances that I get the malignancy? So, if he's symptomatic, the chances are about 6%. If he's asymptomatic, the chances are less than 1%. That is pretty clear. And if the patient has got carcinoma gallbladder, then you'll find stone in almost 70 to 90% of cases. Right? So we're looking at the same problem on both the ways. As far as post-operative incidence is concerned, if you're doing a HP, that is histopathological examination, you do a routine gallbladder surgery, you send the gallbladder for histopathological examination, and you find that on an average, 1% of them would be turning out to be HP positive carcinoma of the gallbladder. Among all laparoscopic cholecystectomies, it's about 2% of these HPs which turn out to be positive for gallbladder cancer, which are then known as incidental gallbladder cancer. As far as presentation is concerned, incidence related to presentation, only one third of the gallbladder cancer patients are diagnosed pre-operatively. That is pretty important figure. That means, despite the fact that I'm having gallbladder cancer, my chance of being diagnosed pre-operatively is only 33%. One third of gallbladder cancer being diagnosed. That is pretty low. And nearly 70% of the cases in US are diagnosed incidentally. That shows that preoperative definitive diagnosis is only 33%. The rest 67% would be diagnosed as incidental either on the table or after. We'll define what incidental gallbladder cancer means. Clinically, only 25% of cases with gallbladder carcinoma would present with resectable lesion. That means if I've got a gallbladder cancer, the chances that it could be operable is only 1 in 4. The 5-year survival figure, look at the overall, it's about less than 5%. So it's one of the the bad cancers to have. Just better than, let's say, esophageal carcinoma, which has got a 5-year survival rate of 2 to 3%. So it's roughly in the same region: pancreatic cancer, gallbladder cancer, esophageal cancer, overall less than 5%. Right? Early stage disease is better, a survival rate of 75%. Now, geographical risk factors. Now, let's talk about the risk factors. What are the risk factors? So, we have said that 10% of the burden of the world is in India. But why does gallbladder cancer really happen? What are the important risk factors? So, first, are geographical risk factors. If you look at the overall stone incidence, is 10 times higher in North and Northeastern Asia compared to South and Western Asia, India. So that means a person living in Madras or let's say Hyderabad or Bangalore would be 10 times lesser susceptible to the disease of gallbladder cancer as compared to a person living in North India, let's say Uttar Pradesh or more Eastern Bihar or Northeast India. Right? If the person has got a symptomatic gallbladder cancer, then it's 20 times higher in North India as compared to South India. So a person in, let's say, Uttar Pradesh, a person in Madras, a person who's got stone. Kindly close the mic, please. Somebody's got the mic on. So the person living in Uttar Pradesh who's got a
Sarah
stone,
recording the call.
20 times higher chance of having a symptomatic gallstone as compared to a person living in one of the southern states. Nature of the stone. North Indians usually have a cholesterol and mixed stone. South Indians usually have a pigment stone. People living in South, they've got a different kind of chemical buildup of the stone, which ultimately leads to gallbladder cancer. Indians migrating to other countries would also carry that high risk along with them. That means a person living in India, if he starts living in US, does not become decreasingly susceptible to carcinoma gallbladder. He'll be at the same incidence of gallbladder cancer. So if you look at the geographical distribution, so we already said North India is more susceptible. So what in North India? It is the Gangetic plain. That means the areas lying along the Ganga are areas where you find the maximum number of gallbladder cancer. The reasons we still don't know. The hypotheses are many. Among them, the important ones, it is probably a pollutant in a human waste or industrial pollutant, or it is mustard oil. And why should mustard oil cause carcinoma gallbladder? We still don't know. Probably some carcinogenic pollutant in the mustard oil, or a pro-inflammatory property of mustard oil, or pesticides, heavy metals, nitrates, all of which are carcinogenic, have been identified as pollutants in the Ganga. High biliary concentration of these pesticides and nitrates have been definitely identified in the gallbladder cancer patient, the bile of the gallbladder cancer patient, but we still don't know whether that is the cause or not. They have been identified, right? Now, what about the environmental risk factors? Among the environmental risk factors are again those which give rise to a number of pollutants, like, for example, petroleum refining industry. The incidence of gallbladder cancer is 3.8 times higher than the normal. Textile paper mill, 1.8 times higher. Shoemaking industry, mining, radon gas, and so on and so forth. And ultimately, higher exposure and fecal-oral transmitted infections like typhoid and H. pylori, right? What are the patient-related factors giving rise to increased incidence of gallbladder cancer? The average age of diagnosis is around 51 as compared to the Western world where it is higher at 71, plus minus 11. I already said the maximum age group is what? 41 to 60. I told you in the first slide. So it is basically the same thing here. Now, the problem is in Asia, it is about a decade earlier you get the higher incidence gallbladder cancer. The reason is probably it is a collection of multiple risk factors which are now acting in an additive manner. What about the sex? We already specified women are at 2 to 6 times higher risk for developing gallbladder cancer. The reason, there are again a number of hypotheses. Number one, the gallbladder mucosa has been found to have estrogen and progesterone receptors, which may promote stasis of bile. That stasis leads to stone formation, and stone formation in turn leads to increased contact time between the mucosa and the gallbladder stone, into bacterial and chemical toxin being released and irritation. Undernourishment may also be an additive factor, and that undernourishment leads towards suboptimal immune status and micronutrient deficiencies, both of which they promote cancer disease. And there could be a genetic incidence of stone disease, right? However, in South India, see the complete reverse or flip. The incidence of malignancy, carcinoma gallbladder, is higher in male as compared to the rest of the country, the north and the northeast, where it is females which are increasingly susceptible. South India, the susceptibility is more in the males, right? As far as parity is concerned, if a female has more than 4 to 6 children, the chance of having gallbladder cancer is higher. Again, has to do with the same estrogen and progesterone susceptibility, and of course the postmenopausal status. What are the other patient-related factors? Number one, genetic predisposition. Number of genetic alterations have been identified. Like, for example, P53. We know that is an important suppressor gene. Now, the genetic factors are probably linked to the lithogenic bile in special populations, and familial predisposition is there. So we know that if I have gallbladder cancer, my child would be increasingly susceptible to gallbladder cancer, and the offspring is susceptibility is almost 2.1 to 30.9 times increased risk. That's quite high risk, right? So my children would be at twice to almost 13 times or 14 times risk of getting gallbladder cancer. So genetic predisposition has definitely been proved. Others, cigarette smoking, irritable bowel disease, autoimmunity. So these are other factors which are patient-related factors making a patient increasingly susceptible to gallbladder cancer. And what about obesity? Obesity, a body mass index more than 30, has got a twice the chance of getting gallbladder cancer. Now, see in India, the flip side or the reverse side is working. There, the increased risk is in low BMI. So if I've got a low BMI and I'm living in West, my chance of getting a gallbladder cancer is less. But in India, if I got a low BMI and I'm living in India, my chance of getting gallbladder cancer is more. So in the West, it is the higher BMI. In the India, it is the lower BMI, which are increasingly susceptible to gallbladder cancer. Now, why does low BMI make me increase susceptible to gallbladder cancer? Probably undernutrition is a main factor. Undernutrition leading to what? Malnutrition, nutrition, and a suboptimal immune status and pro-inflammatory state secondary to micronutrient and antioxidant deficiency. What are the gallstone related factors? So we already said that about 70 to 90% of patients with gallbladder cancer would be having a stone associated. So why does the stone lead to gallbladder cancer? There are a number of factors which have been identified. Number one, the larger the stone, the more the chance of gallbladder cancer. The higher the stone volume, more than 6 ml, the increased duration for which the stone has been there. And that's why I said, if you got a stone in the younger population, let's say in the teens, a patient, a young child with 6 years or let's say 12 years identifies the stone, he has got an increased chance for getting cancer. Why? Because his stone is going to remain there for 20 years, 30 years, 40 years, 50 years. So increase contact time. So the longer the stone is there inside the gallbladder, the more the chance of gallbladder cancer. And that's why, if you remember the last lecture, we said that one of the indications of prophylactic cholecystectomy is a stone found in younger age group. Now you know the reason why you should do a prophylactic cholecystectomy in a patient with asymptomatic stone if his age is in the early or 20s or even 30s, right? Then multiple gallstones. Complicated gallstones. What do complicated gallstones mean? Either with a Medici syndrome or with xanthogranulomatosis, cholecystitis, which we have talked about last time. Now, pathogenetically, why does the stone lead to, why is the stone? Now, obvious question is, why should my stone be lead to malignancy? One, probably constant irritation of the stone cause metaplasia, and that ultimately leads to a genesis of malignancy, right? Then a stone may be associated with a pre-neoplastic lesion. A gallstone provides a surface on which a biofilm can easily form in between the gallstone and the gallbladder wall. So what? The biofilm would be harboring bacteria, and those bacteria can give rise to persistent chronic irritation, chronic inflammation, which could be genetic, which could be the genesis of gallbladder cancer. What are the other gallbladder related factors? A polyp, very, very important. A polyp, if it is there, which is more than 1 centimeter, a polyp which is sessile, a polyp which has got a vascular core, a polyp which is showing rapid growth, and a polyp in a patient more than 50 years are all high risk factors. And that is where prophylactic cholecystectomy is indicated to prevent the formation or the conversion into a gallbladder cancer. Polyps usually are found in only 5% adult population, 5% are neoplastic, and less than 5% of polyps are benign adenomas, right? What is very important is any polyp more than 0.6 millimeter and regular follow-up is essential in these patients, right? What about gallbladder? Other gallbladder related factors, the most important chronic inflammation and responsible for gallbladder cancer in almost 75% of patients. So the stone may also give rise to chronic inflammation. I just now told you biofilm and bacteria entrapped in between the gallbladder surface and the mucosa and the stone surface. Now, what could be the causes of inflammation? Stone disease, I already told you. What are the other causes of chronic inflammation? Salmonella typhi. 167 times risk. See this risk. A very, very high risk. So if you're a chronic typhoid carrier, that means we got typhoid in your body, and if you become a chronic typhoid carrier, you are at a very, very high risk of getting gallbladder cancer. If you got H. pylori infection, again a very, very high risk of gallbladder cancer, especially the H. bilis, which is the malignant form of Helicobacter pylori. Reflux of pancreatic fluid, and then of course chronic cholecystitis and Mersey we already mentioned. What about H. pylori or H. bilis, which is usually found in man? Increased presence in gallbladder stone disease and in gallbladder cancer has been definitely identified. So why does it cause malignancy? Again, it could be a pro-inflammatory state, or it could be altering a inflammation, or it could be promoting carcinogenesis otherwise on the same lines as gastric cancer pathogenesis. This positivity has been shown to be higher in those areas of gallbladder mucosa where there is gastric metaplasia. That means the gallbladder mucosa turns into a mucosa, that particular area turns into a mucosa which resembles the gastric endothelium. Other gallbladder related factors, anatomical aberrations. And which anatomical aberration are we talking about? Most important is anomalous junction of pancreatico ductal system, right? 17.8% incidence of carcinoma gallbladder and usually manifests at a younger age. The reason is probably that the pancreatic juice is refluxing into the CBD. It should be. It should be going to the duodenum. But here reflux is occurring, and that reflux somehow leads to metaplasia and leads to a generalized cancer of the hepatobiliary system, especially biliary system, not hepato, biliary system, that means cholangiocarcinoma and gallbladder cancer. Porcelain gallbladder, the chance of carcinoma is 5 to 6%, definitely proved. We all know that. The porcelain gallbladder could be either diffuse, it could be non-diffuse, and there could be wall thickness. Now, symptomatic porcelain gallbladder are more likely to harbor malignancy. And why does a porcelain gallbladder lead to malignancy? Is it the porcelain gallbladder per se which is causing malignancy? Probably not. It is basically the chronic inflammation causing porcelain gallbladder, which is ultimately carrying on into carcinoma gallbladder. Primary sclerosing cholangitis, again a very high risk factor for carcinoma gallbladder. So this is a flow chart which is picked up from one of the journals, and it shows you a very good representation of the cause of gallbladder cancer. So here you got a gallbladder cancer, patient-related factors, we already enumerated all of them. Then these are the gallbladder-related factors, we enumerated all of them. And then you got certain general factors, which is a toxic environment, and all of them causing a gallbladder cancer. So we got both the parts to it. Now, as far as the pathology of gallbladder cancer is concerned, macroscopically, it is infiltrative in subtle or diffuse thickening of gallbladder, which is the most common type. You could have a papillary manifestation, less than 10%, and these papillary are probably better. Why early diagnosis is usually possible in these. It could be a nodular manifestation. It could be a mixed type where you can have a combination of infiltrative papillary. If you look at the site of involvement, the fundus is the most site to get a gallbladder cancer. The body 30% and the neck is only in 10%. Right? So that shows the anatomical in the gallbladder where you have increased propensity for gallbladder cancer. As far as microscopically is concerned, it's basically you have two types, either epithelial or mesenchymal. More than 99% are epithelial. Among 80 out of them, 80% are adenocarcinomas, and it shows the variety of adenocarcinomas: serous, mucinous, intestinal type. You can read this up. And then the rest are squamous carcinomas or neuroendocrine. So that completes the epithelial types of carcinoma of gallbladder, right? The mesenchymal types, which are rare, very, very uncommon, could be a rhabdomyosarcoma, a leiomyosarcoma, fibrohistiocytoma, Kaposi's, and could be a part of lymphoma, melanoma. But just remember, mesenchymals are very rare. I think less than about 1 to 2% could be a gallbladder cancer. I have not seen a patient with a mesenchymal gallbladder disease, right? Cancer. Now, coming to the spread of this disease, how does it spread? Most important, 50% lymphatics. Then you got the vascular spread, blood spread, as is true for any other malignancy. And with the vascular spread, the primary sites are the lung and the liver, the peritoneum, the omentum. Among them, the first is, of course, the liver, which can manifest in the form of generalized nodular mets. You find the whole of the liver studded with those nodules. It is probably a vascular spread to the liver. But remember, liver is also involved in other methods. In fact, liver involvement is seen in two-thirds of the patients of carcinoma gallbladder. See this figure, two-thirds. That means two-thirds of patient carcinoma gallbladder would be having liver involvement in some form. So if it is vascular, it is generalized metastasis. If it is a direct invasion, which is the next method of liver involvement, then you find a local involvement of segment 4 and segment 5, which is seen in almost 70% of cases of direct invasion to the liver. Direct invasion, which is the third method, you can also see it in the adjacent organs like pylorus, transverse colon, omentum, and peritoneum. The fourth method of spread, so you have the lymphatic, the vascular, the direct invasion, and the fourth method is transperitoneal, which manifests as ascites, omental nodules, and peritoneal implants. And then, of course, the neural spread. And I said earlier, liver involvement in two-thirds. Now, the lymphatic spread is important. That's why I picked up this figure, seen in almost 50% when they manifest for the first time. And there are three pathways of lymphatic spread. The first is the cholecysto-retropancreatic pathway. See this, from here it is coming back to the pancreas. This is the back of the pancreas, retropancreatic. So what are the stations in between? So it goes to the cystic lymph node, the peridocal, from the peridocal, it goes to the retropancreatic, which is the superior and posterior pancreaticoduodenal lymph node. So this is possibly the main pathway, has got two routes, the on the right and on the left. C is going from the right to the spiral, taking a spiral, and posteriorly going straight. So they converge to one large lymph node, and that is the retroportal lymph node. This is the retroportal lymph node. So from here, so it's reached here. So the second is going from here to the celiac axis. See this? So that is going to the left, and the third is a cholecystomesenteric pathway where it is going to the superior mesenteric root, that means to the superior mesenteric artery, which would be somewhere in this region where it so because celiac and down here mesenteric artery. So these three pathways they all converge where? They all converge in the enter aortic cable. So they all please close your mic. Somebody has got the mic on. Kindly close your mic. So you got the inter-aortic cable nodes here, and these are basically the main contraindication for any kind of curative resection. Why? For the simple reason that if you got involved inter-aortic cable, it is M1 disease. Okay, so this is M1 disease, and with this M1 disease, you are basically saying that I cannot go in for a curative resection. Okay, so you got the three pathways just I talked about: the polycystoretropancreatic, then the cholecystocystic, this is cystic, and cholecystomesenteric pathway, which account for the total lymphatic metastasis. Now, the liver spread, I said two-thirds of the patient, right? At the second most common cytometastasis spread after the lymph nodes. Segment 4 and 5, in almost 75% of these, it is segment 4 and 5. How does it spread to the liver? Direct spread 4 and 5, venous spread, and how does it spread by the venous? One, the direct venous communication between the gallbladder and the liver bed, right, through the cystic plate. Then veins accompanying the extrahepatic ducts into the liver. This explains why the initial formation of liver metastasis is basically adjacent to the gallbladder always, right? And then, of course, communication with the portal system. Now, if you look at the portal system, typical question is what are the direct tributaries of portal system? Portal vein, right? Or the portal trunk. One of them is what? The cystic vein. So you got a direct communication with the portal system, either the intrahepatic portal branch of segment 5 or with the segment 4. In either case, you have got a direct venous communication. So that's the third method by which it goes. So vascular is one, venous is second one, and then segment direct involvement. Lymphatic, the portal tract, again lymphatic from. So it has gone from the cystic lymph node to the portal to the porta hepatis. Now at the porta hepatis, if there is a block, what will happen? If you go retrogradely into so it is a retrograde spread subsequent to block at the antegrade pathway of the hepatoduodenal ligament. And vascular, generalized metastasis, and right. So these are methods by which the liver gets involved. The clinical presentations, number one, symptoms, right upper quadrant of the gastric pain is the most common symptom. Jaundice in 10 to 46%, nausea and vomiting, anorexia, and weight loss. As far as the signs are concerned, you get a palpable mass or you can be obstructive jaundice. Now, mass in the right upper quadrant. Why do you get a mass upper right quadrant? Number one, you have a liver lump, which could be a localized liver lump if it is a direct infiltration of segment 4-5, or it could be a generalized liver lump, a modular liver. Then you got a gallbladder lump. It could be a hard lump, or it could be a cystic lump. Right? Now that cystic lump belongs to mucocele. Why? Because there's an growth, infundibular growth, and that growth causes block of the cystic duct, giving rise to a cystic lymph node. Sorry, a cystic glandular lump. So that is the growth at the end. Another reason could be that there is a lymph node pressing on the CBD, and that is responsible for a gallbladder lump again. So either you get a hard gallbladder lump, which is not very common, which can only be seen in very lean and thin persons, or you could be having a cystic gallbladder lump, which is a mucociliary. Obstructive jaundice. Now, why does the patient passing the gallbladder present with obstructive jaundice? One, it could be a direct CBD infiltration. Number two, porta block. And number three, you got a liver metastasis. So, in either of these three, we get an obstructive jaundice. Okay. The third method of presentation is an incidental gallbladder, and that is a gallbladder cancer discovered operatively when you're operating on the patient, or chance finding on a histopathological examination of the excised gallbladder or laparoscopically or by open method. What are the other presentations? Advanced presentation, number one, very umbilical nodule. We all know that Sister Mary Joseph knows. Number two, left supraclavicular adenopathy, the Workhouse alone. The Hughes sign, not the Proteus sign, the Hughes sign, which is a migrating thrombophlebitis. Fourth is pelvic seedings. Mass is palpated on digital rectal examination. We all know that either as a single nodule, multiple nodules, or in the case of Lama shelf. You could be having a precocious or synchronous or metachronous secondary. Now, we all know that precocious basically is not identifying the gallbladder lump, but you find metastasis. Synchronous, you got a lump, gallbladder lump along with metastatic nodule. Or metachronous, you have gallbladder has been operated for carcinoma gallbladder. Later on, this patient comes with secondary. So, where do you find these secondaries as a precocious, synchronous, or metachronous? In the liver, sodium, and in the then T4, if you have T4 disease, it could be a direct spread, and this patient can present with gastric outflow obstruction, or this patient can present with a transverse colonic obstruction, where there is a direct infiltration of the transverse colon. The patient can present with pulmonary spread, features of lung manifestation, or patient can also have bony spread in the form of pain and fracture of the bone. So these are the other advanced presentation of carcinoma gallbladder. Now, differential diagnosis is not very difficult depending on the presentation. So if you got a cystic right hand body lung, which could be a mucosal gallbladder, you could have a differential diagnosis mucosal of the gallbladder, which would be just plain and simple gallbladder stone disease. A hard right hypochondrial lump has got its own differential diagnosis in the form of having a lump from the superior of the kidney, mass, it could be a liver mass, it could be gallbladder mass. Right. Obstructive jaundice, again, a host of other differential diagnosis, whether not a liver. It could be a liver secondaries because of some other malignancy. Let's say carcinoma of the gallbladder, apart from carcinoma gallbladder, stomach cancer, pancreatic cancer. In fact, any of the malignancy in the abdomen, they ultimately go to liver. So that becomes a differential diagnosis. Obstructive jaundice with a smooth liver, again a differential diagnosis. Like for example, you could have a periampullary carcinoma. And ascites, a host of cause of malignant ascites. So what I'm trying to say is that the differential diagnosis would depend upon the type of clinical presentation of the carcinoma gallbladder, and then you have to think of those diagnoses which could be presenting in a similar fashion, right? So you don't have a single list. It has to be multiple methods of trying to differentiate from a host of other conditions. What about the investigations? The routine, we'll forget about the routine. Liver function test, not very important. We are basically concerned with diagnosing. So, as far as diagnosis is concerned, two very important group of investigations. Number one, radiological, and less important, tumor markers. Among the tumor markers, they are both prognostic, they are not diagnostic. And the two important tumor markers which are prognostic is the carbohydrate antigen 99, which is indicator poor prognosis, and more than 20 international units, the specificity is of 79%. It is less specific if the patient has got jaundice. Why? Because even with biliary obstruction, benign biliary obstruction, you could find a high level of carbohydrate antigen 99. And CA more than 4 nanogram per ml has sensitivity of 50%, specificity of 93%. So not very good figure as far as the sensitivity is concerned. And that's why he said CA 99 and CA have got more of a prognostic value rather than having a diagnostic value. Coming to the radiological, which form the mainstay of diagnosis of carcinoma of the gallbladder, diagnostic ultrasound, unfortunately, is not a very good investigation. It has got diagnostic value of only 50 to 75%, and has not been recommended by the NCCN guideline in December 2019 as primarily diagnostic, and that's why ultrasound is not the gold standard for diagnosing carcinoma gallbladder, right? But if you're doing a ultrasound, what would hint towards a carcinoma of the gallbladder? Number one, intraluminal mass. Number two, wall thickening. Number three, liver infiltration,
नाश्ता
especially
करने चलना है
4B and 5, or metastasis. Number four, stones, and number five, polyps. Kindly close the mic. Somebody close the mic on. Please close the mic. So these are the ultrasound features on which are hinting towards ultrasound feature hinting towards carcinoma of the gallbladder. What about the multi-detector CT or the CECT? Slightly better diagnostic capability, moderate sensitivity, but poor specificity. And the problem is that differentiating from xanthogranuloma cholecystitis is difficult, and differentiating from Mirizi syndrome also becomes pretty difficult. But what are the findings that you are finding? Number one, large heterogeneous masses which may have engulfed gallstones inside, areas of necrosis, and patchy to moderate contrast enhancement is usually seen on a CT, which is a multi-director CT examination. Features of advanced disease would include what? You could have intramandibular dilatation, invasion of adjacent structures, where the CT goes over the other other investigations. You could have
नाश्ता करना
invasion
है?
of the duodenum. Please close your mic. Somebody's got the mic on. Please close the mic.
हाँ पानी
Kindly close the mic. Invasion of adjacent structures. You could have lymphadenopathy, you could have peritoneal carcinomatosis, and you can have hepatic and other distant metastases. This is the area where CT scores. Primarily gallbladder cancer diagnosis just on a CT is not a very good method of diagnosing. But a combination of PET and CT, that the PET CT, which is on the PET CT, is probably more sensitive than CT, and it is especially useful. Number one, detecting local residual disease in the fossa. That means you have done a operation carcinoma gallbladder, some disease has been left behind, easily identified by PET CT. A nodal disease identification, distant metastasis, and post-operative follow-up. Again, the PET CT scores over a simple CT. But among all the investigations, probably MRI is very good. Why? Because it shows sensitivity of 91% and pooled specificity of 87%, which is a very, very good figure. Liver invasion sensitivity is 100%. Hepatic lymph node metastasis sensitivity is 92%. And that's why overall, if you ask about one single investigation for diagnosing carcinoma gallbladder, it's probably the MRI which scores over all the other investigations. That means better than an ultrasound, better than a CT scan. In fact, a dynamic MRI is considered to be useful and better, more reliable in staging of advanced gallbladder cancer. Now, just another magnetic resonance imaging advantage is doing a MRCP and sensitive to detection of obstructive jaundice. I'll tell you why, may tell you the reason why the patient has got obstructive jaundice. But more difficult to delineate any invasion to the duodenum or detect omental metastasis by MRI. And that's why what I said is MRI for primary diagnosis and combine it with a CT or a PET CT to look for the adjacent structure involvement, right? The other radiological investigation which can be helpful, you can do a cholangiogram, which could be either retrograde cholangiogram with the help of an ERCP, or you could do a percutaneous route through a transhepatic route, right? Or you can do a endoscopic ultrasound, EUS endoscopic ultrasound, which helps you in giving a better TNS staging, sensitivity of 73% for the diagnosis of gallbladder cancer. Again, a very good sensitivity figure. The endoscopic ultrasound also helps you to do a guided FNAC. Angiogram, preferably MRA, that's a magnetic resonance angiogram, may be useful to tell you what? It tells you about the encasement of portal vein, especially when you're thinking into a radical cholecystectomy where you have to dissect the peridocal lymph node. And then, of course, the chest radiograph for looking at lung metastasis, right? Among all the investigations, staging laparoscopy is now becoming one of the pillars of diagnosis and therapeutics, right? Both for primary and for incidental gallbladder cancer, staging laparoscopy is safe and provides useful information in an additional 20% patients apart from the MRI and CT. How does the laparoscopy help? Number one, visualization, and number two, biopsy, right? So, staging laparoscopy is important. It helps you to do a biopsy laparoscopically, right? And you can visualize the lymph node. The other investigation, of course, is a biopsy, which can be ERCP guided, brush biopsy through the ERCP route, or the guided needle biopsy. The guided could be through an endoscopic ultrasound, a simple ultrasound, or CT scan. So you put the needle into the liver mass. Remember, the gallbladder is never biopsied. The FNAC is never taken from the gallbladder mass. You can do a bile cytology, or you can do a biopsy, which is there only in stage 4. Why? Because stage 4 is a cancer which is deemed to be incurable. The patient has to go there. A needle biopsy may be justified, but remember, not indicated in any other stage of gallbladder cancer. So the only need or the only indication of doing a biopsy in a gallbladder cancer is either a biopsy from the liver mass or taking a ERCP guided brush cytology. And the European Society of Medical Oncology 2016 guidelines for diagnosis of for gallbladder cancer, see it is based on MRI with MRCP, contrast enhanced, and CT is less useful except for trying to diagnose local extra hepatic and extra biliary infiltration into the adjacent structure. Now, staging laparoscopy, I told you, is very important, becoming a pillar, and the NCC guidelines guidelines in 2014, the Asian Hepatobiliary Association consent statement says that staging laparoscopy is an important adjunct in diagnosis. In diagnosing peritoneal implants, you can obviously see and take a biopsy, liver mets, and nodal disease outside the hepatoduodenal ligament. That basically means what? Hepatoduodenal ligament has got only peridocal lymph node. So which lymph nodes are we talking about? The celiac, the retropancreatic, intrahepatic, all are contraindications for radical resection. That means the moment you go to beyond peridocal and retropancreatic lymph node, the superior retropancreatic, they become contraindications for radical resection. The staging laparoscopy may be combined with endoscopic ultrasound. If possible, celiac and intracaval lymph node sampling is a must. If you can do it, if you do it and you find two positive, that becomes a patient. That is a patient who becomes incurable in the sense they can't go in for any kind of resection. So please do not try to do a radical cholecystectomy in a patient who has got a positive metastasis to celiac or intracaval group of lymph node. And in a frozen section to confirm before radical resection. If indicated, subsequent to staging laparoscopy, you can go ahead and do a laparoscopic or an open conversion. Now, these are guidelines for workup of known or suspected. See, known or suspected gallbladder cancer patient. So you have a pre-operative mass identified. That means you got a gallbladder lump pre-operatively. You can carry out these investigations, right? Incidental finding at surgery. The investigations mentioned out here. Incidental findings on pathology. So incidental at surgery, incidental pathology, that means HPE. What should you do are mentioned out here. And unresectable, basically on staging laparoscopy or imaging, biopsy if tissue not available, genetic testing. These are the guidelines for workup of known or suspected patients of gallbladder cancer. Now, coming to staging, and the usual staging, apart from T and M, are two stagings. One is the Down modification Neville's classification. It tells you the original Neville's classification. Stages in five, very simple. Here, mucosa, muscularis and mucosa, subserosa, muscle layer, and invading wall layer of gallbladder wall. And five is extension beyond the gallbladder into the liver or the distant spread. Right? Now, the Donohue's modification is modifies this 5 into 4, and it is simple that stage 1 to 3 limited to gallbladder, local disease. Stage 4 is lymph node metastasis. Stage 5 is liver or distant metastasis. Histological grade cannot be assessed, well differentiated, moderate differentiated, poor differentiated. Among all these, apart from these, the better method of now classifying gallbladder cancer is the TNM staging. And this is the TNM staging, which is an important part of staging gallbladder cancer at unit stage. But just remember one thing, and that is the stage 1, T1, that is the primary tumor T1, is it's remain in lamina and muscle layer. Two, it goes beyond into the peritoneal side. See, I've shown a figure out here. So you got the lamina propria here, T1A, and this 1S is carcinoma C2. This is the lining wall, this is the lumen of the gallbladder, this is the gallbladder, and see the serosa is missing here. In contact with the liver, remember when we talked about anatomy of the gallbladder, we said that in the region of the liver, the gallbladder attachment, the serosa is not there. So here the serosa is not here. Serosa stops here. So T1S is limited to the gallbladder mucosa. Here lamina propria goes into the muscle. It is still T1 but becomes T1B. So remember, muscle layer and inside is all T1. T2A becomes when goes beyond the muscle into the connective tissue between the serosal layer and the muscular layer. That is 2A. And 2A has got two parts to it. 2 has got two parts to it, 2A and 2B. So if you look at this gallbladder very carefully, here you got the liver, here you got the gallbladder, which is toward the peritoneal side. So if you've got a serosal involvement at the peritoneal side, and you got a serosal involvement at the liver side. So toward the liver side, still not infiltrating the liver, it becomes 2B. Serosal side toward the peritoneum, still not infiltrated beyond the serosa, 2A. And 3 becomes with gone beyond the serosa, 3A to the peritoneal side, 3B into the liver. So basically, when you got a local extension beyond the confines of the serosa, it becomes T3. If it is still within the serosa, beyond the muscle, T2. Simple, right? And muscle and everything inside is T1. So if we look back at this figure, this is basically the same thing. As far as nodal state is concerned, just two groups, N1 and N2. And for diagnosing or for classifying for of the N, what is very important is that lymph node sampling has to be done, and minimum of 6 lymph nodes are required. Remember that. Don't forget that. Minimum of 6 lymph nodes have to be biopsied to give a correct TNM classification. M0 and M1 are pretty simple, and this shows you the staging of the gallbladder cancer. Now, coming to the treatment principles. What are the treatment of gallbladder cancer? Surgery is the mainstay. Remember that. Surgery is the mainstay of treatment of gallbladder cancer. No two views about it. But the problem is, I told you only one-fourth of patients would be coming in stages where you can carry out some kind of surgery. So surgery is amenable only in 10 to 30% of patients. That means one-fourth of patients. It should always be a curative intent. Remember, there is no indication for doing a palliative resection of gallbladder cancer. There is nothing like palliative gallbladder cancer surgery. If you're doing it, you're scientifically wrong. Now, there are certain definitions required for gallbladder cancer surgery. You got R0, R1, and R2. R0 is again margin is free. And remember, this classification of R0, R1, R2 is similar across all GI malignancy. So once you have done a resection and the margin is free of any kind of malignancy, then it is R0. If you find the margin appears to be free, but on doing a histopathology, you find that there are infiltration of cells, it becomes R1. And if you have done a resection, and obviously you can see it on the table that what you've resected is through a growth. That means the margins have got the macroscopic growth, and that becomes a R2 disease. Chemo is induction chemotherapy, or as adjuvant chemotherapy, or as a palliative chemotherapy, right? Chemoradiation is the second method, and then EBRT, that is the external beam radiotherapy, are the choices available for treating gallbladder cancer. As far as the surgical principles are concerned, the principles of treatment are simple. The clinical settings in which a surgical treatment is required. Number one, for the primary operation, that means preoperatively I've been able to diagnose if this patient has got carcinoma gallbladder, I'll carry out this treatment. Simple. That's the primary operation. We know that. Secondary operation after incidental discovery. That means incidental gallbladder cancer. What is incidental gallbladder cancer? We just talk about that. Residual disease management is basically I have removed a gallbladder and some part of the disease has been left behind, which is seen later on diagnosis of CT or routine CT, and then I do an operation for that. That's residual disease management. Liver bed management. What do I do? The liver bed. The patient's got gallbladder cancer, cystic stump, and extrahepatic biliary duct management, port site management, and adjuvant palliative therapy. So these are basically clinical settings in which the treatment principles would be directed at. Right now, anatomical basis gallbladder resection, you have to remember that the gallbladder wall does not have a submucosa. If you remember my first lecture on gallbladder anatomy, I told you that there is no mucosa. In addition, the second thing very important is that where the gallbladder attaches to the liver, there is no serosa there. There is no serosa. So a direct infiltration gallbladder into the liver comes very easy because serosa is one of the barriers for onward spread, and the serosa is missing between the gallbladder and the liver at in the region of the cystic plate. So there it becomes very early and very easy for infiltration into the gallbladder. So two anatomical factors which have got an important bearing on the spread. One is that there is no submucosa. That's why it spreads very early into the muscle layer. And number two, there's no serosa between the gallbladder and the liver at the site of attachment. So there, direct infiltration liver becomes very easy. The cystic plate does separate the gallbladder from the liver. This cystic plate is nothing but a fiber areolar connective tissue. It's got a lot of lymphatics. It's got vessels which form a communication between the cystic and the veins of the segment 4 and segment 5, right? And well formed in the gallbladder body and gets thinner towards the gallbladder fundus. So toward the fundus, remember the fundus is the area which has got the maximum incidence of gallbladder cancer, and there the cystic plate is very thin. So all the factors are basically trying to push towards a very early infiltration to segment 4 and segment 5. That means a thin cystic plate, absence of serosal layer in that particular area are all conducive to an early spread of the gallbladder cancer into the liver. Cystic vein, the venous drainage of the fundus and body is mainly to the liver bed. That's an again reason why it will be spread into the liver. Cystic vein is present uncommonly. So remember in anatomy, we only talk about cystic artery, cystic artery, cystic artery. We never talk about the cystic vein. Why? It is uncommonly present, right? Usually either a single twig or multiple twigs, and they run parallel to the cystic artery on the cystic duct, cross the callus to open to the right branch of the portal vein. They never cross the right hepatic duct or the CHD. And small bile ducts may always drain the gallbladder into the liver bed and then the ducts of Lushka and have to be taken care of when you're doing a radical cholecystectomy. Now, when you're doing a surgical resection, what are the options? One, you can do a simple cholecystectomy, but the other options which are pretty definite and more for gallbladder cancer is a radical cholecystectomy. The original is the Glenn operation 1954 and still continuing, and that is the cornerstone of curative gallbladder resection, radical cholecystectomy. Number two is extended radical cholecystectomy. Number three, you can go in for organ excision. That means you can go in for transverse colon which has been infiltrated. If the stomach is infiltrated, the pylorus is infiltrated, you go in for excision of the pylorus. If the pancreas is infiltrated, of course, conditions conducive. The variables hinting towards these kind of every patient with gallbladder cancer infiltrating into the stomach may not be amenable to surgery. There are definite indications for surgery, so you can do it. Pancreatic duodenectomy can be done, omentectomy can be done, and then of course other surgical options. But coming to the most important, radical cholecystectomy, what does it include? Number one, cholecystectomy. Number two, wedge resection of a rim of non-neoplastic liver tissue, approximately 2 to 3 centimeters in thickness, from segment 4 and segment 5. Remember that. You're removing the adjacent 4 and 5. If it is macroscopically evident is infiltrated, then take a margin of 2 to 3 centimeters of obviously appearing normal liver tissue. Number three, the third thing to be removed, complete cystic plate. Number four to be removed, portal lymph node dissection in an en bloc fashion. And should include what? Cystic, porta hepatis, gastrohepatic, that is periducal, and retroduodenal lymph nodes. Right? So, what does radical cholecystectomy include? Gallbladder, wedge resection of segment 4-5. Number 3, excision of cystic plate. Number 4, complete lymphadenectomy, which should include cystic, portal, periducal, and retroduodenal. So, we are going down from the cystic, we are going into the porta hepatis, going further down periducal, and further down retroduodenal. If you are doing all these things, you are doing a complete radical cholecystectomy. And the radical cholecystectomy suffices for all primary tumors as 1B, T2, T3. Remember, basically 2 and 3 are what? 2 is basically when you go into the muscle layer, and 3 is basically when you're looking at the when you're looking at the beyond the serosa. T2 is basically you're involving the serosa. So with localized hepatic invasion, you can still carry out a complete radical cholecystectomy. What is extended radical cholecystectomy? The extended has to do with the extent of regional lymphadenectomy, that we are going further down beyond the retroduodenal into the pancreaticoduodenal and the interiocaval and the cystic lymph node. That becomes the extended radical. And the second extension of radical is basically the extent of liver resection. So in addition to just the doing a wedge resection, you're doing a complete anatomical excision of segment 4-5. You're doing a right hepatectomy. You're doing a trisegmentectomy. So the extended radical differs from a radical cholecystectomy in two aspects. Number one, you're removing more lymph nodes beyond the retrojudinal, and you're removing more of the liver beyond the wedge resection of segment 4 and 5. So remember, radical cholecystectomy, wedge resection of liver. Extended radical cholecystectomy, it is either a complete anatomical excision of segment 4B and 5 of liver, right hepatectomy, or trisegmenectomy. What about prophylactic CBD excision? Not indicated. Never. Prophylactic. Remember, that's why I have shown the word prophylactic. Now, prophylactic CBD excision is never indicated, right? And lobectomy prophylactic is not indicated beyond the required. Why? Because we did not get any better survival figures if you're doing a prophylactic CBD excision or prophylactic lobectomy. The survival figures do not increase. In contrast, the morbidity increases, and that morbidity increase leads to a lot of problems. So that's why I said lesser operative management is always better. Resection of adjacent involved organs, stomach, duodenum, pancreas can all be carried out. So these are the surgical options overview. It shows staging laparoscopy. I told you about the staging laparoscopy. It gives the highest yield in both non-incidental gallbladder and T3 or greater. Initial exploration, uh, the hepatic resection, we already talked about what should be done. Lymphadenectomy, bile duct resection. C. Routine resection is not recommended. What we just now said. Port side resection, we'll talk about port side resection in a short while. Extent of resection, and that would depend upon the presentation and how much you have to do. Right? So, based on the primary tumor stage, that is the T, presenting symptomatology. T1A, that limited mucosa, simple cholecystectomy is good enough. You don't do anything else. That means if the report of HPE comes as simple mucosal disease, forget about it. That patient does not require any surgery. If it is T1B, that means lamina propria or larger lesions, greater lesions, all would we have to do a radical cholecystectomy with or without bile duct excision. Hepatic resection would depend upon the degree of involvement. So now you're talking about radical cholecystectomy or extended radical cholecystectomy. What happens to T4 tumor? We said T4 basically is one where it is going into the adjacent organs. So if it's in adjacent organs, this T4, the majority are unresectable, but the word important is majority. That means some may be resectable. So what tells you that a PT4 or the primary T4 stage is unresectable? What tells you is unresectable is the patient got metastatic disease, that means he's got a celiac or intrahepatic lymph node positive. Please do not go in for any kind of surgery. Port hepatitis involvement in the form of main portal vein or the right portal vein or the hepatic arterioids branches, or involvement of one side hepatic, other side portal vein, or simultaneous involvement of both the lobes. Please do not go in for any kind of surgery in such instances. So that becomes a contraindication for any kind of radical resection. Or if there is contiguous involvement of more than two segments each in both the lobes of the liver, again a contraindication for any kind of surgery. But in those patients with PT4 who can be operated upon, and you want a R0 margin, remember what we said? Curative excision. Curative excision means what? R0 margin, not R1, not R2. So if you're talking curative resection in PT4, that means for T, right? So what do? If it is a fundus, you may require major liver resection or adjacent organs. If it's infundibular growth, you may require bile duct excision, duodenal duct excision. So basically, what we're trying to say is that it has to be a major surgery. But does it really help? The survival figures and compared to morbidity figures, they do not tally with each other. So probably not. You would not like to do the kind of surgery. So depending on the stage, what surgery will you do? Patient in stage 1, remember that is T1 is stage 1, simple cholecystectomy, already said that. Stage 2 is P2A or 2B, radical cholecystectomy. 3, N0 or T1 to 3, N1, radical extended radical cholecystectomy. 4A, that is T4, extended radical cholecystectomy. 4B, Metz disease, palliative. And if the patient got jaundice, remember the treatment has to be neoadjuvant therapy with percutaneous or ERCP decompression. Why? Because you have to decompress the jaundice. You have to make this patient anecteric. So if you make this patient anecteric, the symptomatology, the morbidity increases. So that is stage-wise surgical option. Now coming to incidental gallbladder cancer, you've done a cholecystectomy. You send the specimen for histopathology, which is routine, and in comes a report which says that the report is positive for gallbladder cancer. Or pre-operative, you did all investigations, there was no hint of gallbladder cancer, and you opened the abdomen either by open surgery or laparoscopically, and you find gallbladder cancer in front of you. A third scenario could be that you remove the gallbladder, and remember, it's a dictum that every organ which is removed should be opened up, especially tubule. So when you open up the gallbladder slit, you remove the gallbladder on the table, and outside your resident opened up the gallbladder to see the inside of the gallbladder, and he finds a growth inside the gallbladder. So three scenarios where you get a gallbladder cancer, which is known as incidental gallbladder cancer. Very, very important part of gallbladder cancer management, incidental gallbladder. So found at cholecystectomy for benign gallbladder disease. I told you the scenario, and I told you the second scenario. Now out of these scenarios, 50 to 70% are those who are diagnosed on a, which is the most common scenario for diagnosis of incidental gallbladder cancer. If you're looking at an incidental gallbladder cancer, the HPE report will be available only when you give enough tissue. So, what is the tissue which is required, which should be processed? Number one, three representative sites of the gallbladder and the cystic duct. That has to be processed by a pathologist before you can get a complete picture of HPE. And what you're looking for, I've enumerated. I'm not going to read this out. Just look it up. What is to be seen on a HPE, right? Now, the patient preoperatively was not diagnosed. Per-operative, as soon as you put in the laparoscope inside, and in front you find that this patient has got a gallbladder cancer. Now, immediately, what to do now? One, first option, take a biopsy in front of you, do a frozen section. That means the patient is still in anesthesia, you're doing a frozen section, report available within 40-45 minutes. As soon as report comes positive, if you can do a staging, if you can do a staging, in the meantime, while the frozen section was being done, you looked up the whole of the abdomen, you looked at the lymph nodes, you look at the retropancreatic area, and you find there's no disease, and or even if there's disease, you are a trained biliary surgeon, go ahead and do a radical cholecystectomy. Go ahead and do it. But you're not a trained biliary surgeon. Please do not do anything else. Just take a biopsy, do a laparoscopy, identify areas of involvement, note them down, close the abdomen, and then send the patient to a more experienced center or save the patient for a later day, right? If the staging is not possible per operatively, that means you open the abdomen for benign disease and you cannot, you now you identify this patient does have a gallbladder cancer and you're not able to operate on that patient, you're not able to stage that patient. I don't know whether lymph node involved or not. I'm not very clear. I will not do anything. I will just close the abdomen. I'll do restaging with other investigations outside, and then subsequently I may take this patient again for radical cholecystectomy. So that is a scenario which the answer to your question, what to do if gallbladder cancer is identified for the first time on the table per operative. The second is the gallbladder cancer. I told you the more common is on HPE, 50 to 70% on HPE. And the question is, when the report comes as positive, now the question is, what should I do? What should I do? Now, immediately, should I again take this patient up for surgery? A very burning question, very, very important question. The first thing is, as soon as the report comes positive, the first thing I will do is I will restage this patient by repeating the CT, MRI, PET, and I will do a staging laparoscopy at the time. Again, go back in, do a re-laparoscopy, and do a staging laparoscopy. Once I have that, I'll also look for other features or other variables which may have a bearing on the ultimate results. Like, for example, if there had been iatrogenic perforation while I was doing a lap poly, and this patient ultimately the biopsy came out to be positive, and they had been iatrogenic perforation. Remember, these patients, even if a retrieval bag was used, recurrence of gallbladder cancer is significantly more. If there had been biliary spillage during the lab chole in a patient subsequently identified to be having HPE positive gallbladder cancer, these patients were having a increased recurrence and decreased disease-free survival. If I did not remove cystic plate and later on my cholecystectomy specimen came out to be HPE positive for gallbladder cancer, again that patient will be increasingly susceptible for recurrence. So, as soon as a HPE report comes to you as positive, then you have to restage this patient, reassess, restage, and look for poor prognostic factor. Once you have done that, Once you've done that, and now you're going to restage it as either T1S or T1A tumor, which is basically what? T1S carcinoma C2, T1A is what? Lamina propria. If you find that the HP report says cystic duct margin is clear and all other margins are clear apart from the growth, don't do anything, forget about the patient, just follow him up. The cure rates are almost 85 to 100%. But if you find that the report shows cystic duct margin positive, go back in, do a CBD excision to a negative margin, and even complete CBD excision plus hepatocytogenoscopy, that means residual metastatic disease positive, then you have to go in and treat it as a stage 4B. So in all these patients where you got T1S or T1A tumors, you have to deal accordingly. But if your restaging shows it to be a T1B, that's a muscular layer involvement, do a re-resection radical cholecystectomy. Now you'll call it what? Re-resection radical cholecystectomy. And that will include a lymphadenectomy with or without CBD management. I just now told you CBD management would only be if the cystic duct is involved or CBD is directly involved. Remember that. No prophylactic CBD management is ever required. T2, where you got a perimuscular connective tissue involvement, re-resection radical cholecystectomy required. T3 limited disease, re-resection radical cholecystectomy only if limited T3 and lymph node metastasis. If it is extended T3, remember T3 is what? T3 is basically going beyond the serosa, up to the serosal layer, not beyond the serosa, up to the serosal layer, and then when you got the perforation beyond the serosal layer, it becomes extended T3, and these cases are having a extended radical cholecystectomy. Stage T4, where it's involving the adjacent organs, then the extended radical resections are with doubtful benefit. So it has been mentioned that I can do partial gastrectomy, I can do Whipple's operation, I can do a duodenectomy, I can do everything what I want. Why kill the patient on the table or why make the patient more morbid? So as of now, these extended radical cholecystectomies along with extended radical resections, cholecystectomy and extended radical resections are those which can be tried only in scientific settings in very highly specialized units. Otherwise, as a rule, should not be done. And all these results are basically SEER results. You all know the SEER, which stands for surveillance epidemiology results. Now, never forget SEER, that's common to all malignancies, right? Now, the National Comprehensive Cancer Network recommendation, we will talk about NCCN, this is basically what it means. So, what does it recommend? Re-resection radical cholecystectomy in these patients. You go back in, what do? You're going to resect the cystic plate. You're going into a more extensive veg resection or anatomical resection, section 4, 5, and this is where it is a re-resection radical cholecystectomy, just slightly different from that. If the gallbladder was not removed with or without a bag of perforated gallbladder, should I go for prophylactic port-side infection resection? I'll talk about that in the next slide, right? But the burning question is, HPS turned out to be positive. I've done restaging everything, and I have restaged it as, let's say, T2. Now the question is, when should I reoperate on this patient? You call the patient back and you say, look, you've got a malignancy and I would like to reoperate. The question is, when? That is a very important question. So time is very debatable. I can go early, that means within, let's say, about 2 weeks. I would say come back within 10 days and I'll reoperate on you. Now, early resection to achieve maximum disease-free survival, I would be tackling the malignancy as early as possible. But what has been quoted is now 45 days or 3 months. That basically 1.5 months or up to 3 months, 1.5 to 3 months of undergoing simple cholecystectomy. That is the time period which is probably beneficial and better to intervene. Why? This long waiting period does not result in any alteration in survival figures. Very important. Gives an indication of biologic behavior of this growth. So within those 45 days, growth very rapidly. No use of operating on this patient. You're going to kill the patient. So it tells you the biologic behavior of this growth. So it's very rapidly growing. So those 45 days will give you a time to assess whether it's a very rapidly growing, a slow growing, or a moderately growing. It also avoids unnecessary surgery by identifying those patients who may not benefit from any kind of surgical resection, right? So this is why this time period of 45 days to 3 months, that means 1.5 to 3 months, is the time period which has been advised to be taken as the time when you go in for a reoperation. What about residual disease? That means I have removed everything, but on doing a PET scan, I found there is a residual disease and my HPE was positive. What should I do? Now that would depend on biology and that residual disease. If you exercise or not exercise, basically the presence of residual disease alters the survival figure. So if there is residual disease left behind, the survival immediately 5 year comes down to 19%. No disease, 74%. Right? And what are the risk factors for residual disease? T3 tumors, perineal invasion, and lymphovascular invasion. So you have to go in and remove the residual disease. What about port side mets, which is a very, very important question. Now, port side mets, just a look at the port side mets. That means you have done a laparoscopic cholecystectomy. What is the port side met? You have done a laparoscopic cholecystectomy and everything was hunky dory. The patient had a HP report positive of malignancy. You were waiting. Should I go in and do something or not? And the patient comes back to you within 1 month and he shows a growth, a hard nodule in the area of one of the ports. Now immediately alarm bells start ringing. This is a port side or maybe a port side mets. So the incidence of such kind of manifestation, where after delay of laparoscopic cholecystectomy, you find that there is a growth, nodular growth or a nodularity at the port site, is found in 40 to 9% of patients within 6 to 10 months. 40% with gallbladder perforation would come with these port side mets, right? Now, there could be a number of reasons, hypothetical causes initially in the start of laparoscopic surgery. They said it was carbon dioxide, which was the carbon dioxide pneumoperitoneum, and when it escaped through the port side, the carbon dioxide escaped the port side, it carried those seedlings of cancer cells and would implant them at the port side. So that was basically direct mechanical contamination or indirect mechanical contamination, which is known as the chimney effect due to leakage of gas along the trocars. Then changes in host immune response, hematogenous dissemination, and poor surgical technique, all reasons which were described to be the reasons for port side met, but no longer. What is probably true now is that the port side met is an indicator of advanced peritoneal disease. None of these factors are important. What is important is that if you got a port side mets, remember this patient has got an advanced peritoneal metastasis, and more often than not, you'll find peritoneal metastasis in such patients. Very common. Poor prognosis, 1 year survival is less than 30%. And recurrence after excision is the rule. So that means you basically look at port side medicine and you tell this patient, look, I'll remove this and you'll be free of cancer. And what do you have? You have a recurrence again. So remember, please do not go in for early excision port side meds. You have to properly evaluate before you go in and do a port side meds. And all these port side meds, these patients will be having a lymph node positivity. So the question is that when this patient came back with a histopathology report in his hand with HPE positive for malignancy, my immediate question to myself was whether I should reoperate. And even if I do not reoperate, should I just remove the port side? Should I do a prophylactic port side excision? That was the second question I was trying to address to myself as a surgeon. Routinely, remember, port side should not be prophylactically excised. Should not. Please do not do a routine port site excision under the belief or assumption that this patient will probably be having some kind of malignant cells implanted there, which would ultimately clinically manifest themselves. So, no routine port site met excision in IGBC. That means incidental gallbladder cancers, HPE diagnosed. Please do not go ahead and do a port site excision. It's only indicated. So port side excision indicated when the gallbladder was perforated or the gallbladder is not removed in a bag. In those cases, yes, go ahead and do a prophylactic port side excision. But port side excision prophylactically increases the morbidity in the form of occurrence of ventral hernias to the tune of 15%. Because a large excision has to be done, you create a large incision, large defect. Now coming to the just a few slides remaining. Alternative therapy, what else can we do? Chemo is a very important, and chemo is given as a standard therapy as an adjuvant or neoadjuvant. We already told you that. The standard therapy is gemcitabine, which is an anti-metabolite, and the first line biliary tract cancer and gallbladder cancer is gemcitabine. So 28-day cycle, 4 cycles required, and I've noted down the drugs for you. So it is a combination of gemcitabine and cisplatin. You can just note this down. You can look it up when I load this up onto YouTube. Gemcitabine can be combined with oxaliplatin. It could be a triple therapy of gemcitabine, cisplatinum, and paclitaxel, or you can have gemcitabine or a fluoropyrimidine-based chemotherapy in the form of capecitabine, which is a product converted to 5-FU. These are oral tablet. So either of these combination can be used, but the standard is a combination of gemcitabine and cisplatin, right? This first one, the standard therapy, is the standard adjuvant therapy. Then the NCB recommendations for alternative therapy is basically when you talk about external beam radiotherapy with concurrent fluoropyrimidine, plain and simple external beam radiotherapy. For best supportive care has to be there, adequate biliary drainage, nutrition. Targeted genetic mutation therapy is now coming to fore. They are trying it out now. Clinically, still not being done routinely. And what is most commonly being used is pembrolizumab. And this is basically only used for those patients who genetically show very high microsatellite instability or deficient mismatch repair. Stage wise, patients with resective biliary tract cancer should be offered adjuvant capecitabine chemotherapy. I just not told you that. So it forms the cornerstone of adjuvant therapy. Chemotherapy is the cornerstone of adjuvant therapy in all patients identified with carcinoma gallbladder disease. Those with R1 margin, remember microscopically positive margin, should be considered for chemoradiotherapy. So there you should also combine radiotherapy in these patients. In advanced T3, T4, neoadjuvant chemotherapy should be started. So chemotherapy given as a standard adjuvant, given in combination with radio, or given as a neoadjuvant in patients with T3 and T4. These are the targetable genetic mutations. We talk of P53, and there are others, and these are the drugs which are being used. I'm not going to go into the details. I'm going to read them up. Just look it up. I've told you the source. It is in SCNA April 2019 issue. You can look it up. And that shows the genetic alterations and genetic manipulations which can be used as potential therapeutics in gallbladder cancer. Finally, the recurrence pattern, median time to recurrence after gallbladder cancer is about 11.5 months, roughly 1 year. Locoregional liver bed found in 15%, the rest 85% are called a generalized recurrence. And this recurrence, among them, the most common is peritoneal. You can have a lymph node recurrence. 5 year survival rates post treatment, that is post treatment, not overall. Post treatment is stage wise 100%, 85%, 50%, depending upon stage 1B advanced. If you look at overall, 2 to 3.5% median survival 6 months. Overall 5 year survival, so this is after post treatment. This is 5 year survival rate, and you can look at the 5 year survival rate is somewhere OS is overall survival 85.9 to T4 14.1. So that is basically survival rate in the malignancy of the gallbladder. So take home message: early diagnosis of gallbladder cancer is imperative for cure. Number one. Number two, majority of gallbladder malignancy are diagnosed incidentally. That means only 1/3. My chance of getting gallbladder cancer being diagnosed preoperatively is 1/3. 2/3 chances are that it will be diagnosed on histopathological examination or on the table. So majority are diagnosed incidentally. Remember, radical cholecystectomy is acceptable procedure, can be done in those patients as indicated. Gallbladder should always be opened and examined. The gallbladder which has been removed should always be opened and examined macroscopically on the operation table to look for any macroscopic disease in the form of cancer, representing cancer. Morbidity and mortality of extended radical cholecystectomy make its use debatable. So, in a nutshell, if you ask about the treatment for gallbladder cancer, it is radical cholecystectomy if possible. Otherwise, don't do anything. Please do not go in for extended resections. Please do not go in for extended radical cholecystectomy. These are basically mentioned that they can be done in highly specialized units, but as a routine, they have very high morbidity. So it has to be weighed in terms of the survival figure, whether you should really subject a patient to extended radical cholecystectomy or extended radical resections. Most important predictor of survival after treatment are number one, tumor biology, the stage, and not the extent of your resection. Thank you for your time. I'll load this up either today or tomorrow onto my YouTube channel. You can have a look at it. And those who have missed this lecture, they can go ahead and look at this lecture. Thank you for your time. If you have any questions, you can always come back to me.